Good morning, everyone. We're going to get started. Today, I have the great privilege to introduce Dr. Monica Gandhi. Dr. Gandhi is a professor of medicine and the associate division chief of our division of HIV, ID, and global medicine. Dr. Gandhi is also the director of the CFAR at UCSF and the medical director of our clinic here at Ward 86. Dr. Gandhi is a phenomenal educator and HIV expert and a true mentor to me. And we are so lucky to have Dr. Gandhi come today to give us updates from the 25th International AIDS Conference. Her title is called IAS in Action, HIV Clinical Insights from Munich 2024, or highlights, sorry.
Okay, thank you. Really happy to present this to you. I think that what I'll be talking about today, sometimes we all present when we haven't been to a meeting, but I have to say that I was at this meeting and a lot of the insights were gained from just being there, from the question answer period. So I'm going to tell you about what I heard that I think hopefully will put some of this data in context. So, okay, so we're going to review actually three major areas: AIDS 2024 data on prevention, on treatment, and on comorbidities. And we'll focus on weight gain and hypertension for the latter. So we're going to have a lot of questions here. So I want please to get out your clicker and say, why don't you let me know what percentage of people worldwide living with HIV are virologically suppressed? Oh, sorry, it says 66, 72%, 80. Are we at target 95, 95, 95 at 86% or 90%? So please vote. Do I advance it, Liz? And then, okay. So 67% of people so far have said 66% and 33% are 72%. And none of you are more optimistic than that. And I think that's a fair assessment. It is actually 72%. At least by the data that can be gleaned from UNAIDS. So every 2 years, there's a big international AIDS meeting like there was in Munich, and then every 2 years is a smaller scientific meeting. And coinciding with the large international AIDS conference is the update from UNAIDS that Dr. Havlier covered last week. And I just want to point out that there was really zero difference in incidence and mortality in 2024 than the 2022 update, which and many people found very depressing because there hadn't been that progress of decreasing new infections or deaths. So over 40 million people, if we keep in mind that 39.9 doesn't include statistics from Russia, over 40 million people living with HIV, 1.3 million new infections last year, 630,000 deaths, and only a 72% virologic suppression rate. So those who are living with HIV, 72% are suppressed. And I think that we all know this because we're living it, but there is, in the report, there was a discussion of this, what's going on in the world right now with rising stigma and discrimination and anti-LGBTQ laws and social inequalities and violence and conflict, and all of that leading to that with a complacency that has led to a decrease in HIV funding are fueling this setback in the HIV response. And so this is our work to do. So let's go forth and talk about these three areas and the key clinical updates from AIDS 2024. So let's start with HIV prevention. Now, this is a question for you, and actually I don't know the answer to this. So after AIDS 2024 and approval of the latest medication for PrEP, what options do you think we're going to have for PrEP for cisgender women? Is it going to be daily TDF-FTC, cabotegravir, and lenacapavir? Is it going to be daily TDF-FTC? We're going to add TAF-FTC after AIDS 2024, cab-len. Is it going to be on-demand TDF-FTC, daily TDF-FTC, cab-len? Is it going to be all options that are available, likely, that are going to be for non-vaginal sex, which is number 4? Or who knows what the FDA is going to say about kind of the oral options that are going to be presented to them? So please vote. Okay, I think this is excellent because it's divided between the three that I think it's going to be. On demand is not available. For cisgender women, it hasn't been studied. So that's perfect. No one said C or D. But the question is, will the data from the Purpose One study on TAF FTC lead to its approval for women? And I'm not so sure. And I think we were also divided in this audience. So who knows what the FDA will say, right? It may just be that they add on LEN after Purpose One, but they do not add on TAF FTC. So let's go over that data. So lenacapavir has to work at some points in the viral life cycle that are beyond just viral capsid formation at the end, because anything that's going to be studied as a preventative agent should have some study earlier on in the life cycle. So at least this is a figure from the drug company, maybe nuclear transport, maybe starting earlier on in the life cycle. But this was the biggest deal at the meeting, and it was hard to it's hard unless you were there to convey that this was so predominant that I think there was kind of jumping the gun sometimes of other data. And also the fact that yet, based on this data, there's not going to yet be filing for approval of lenacapavir because the Purpose One study was done in cisgender women, but the Purpose Two study done in men who have sex with men, transgender women, and non-binary individuals, we don't have that data until I think hopefully it'll be presented at CORE 2025, but I think it'll be at the end of this year. And so despite everything that went on in the meeting, there's not going to be filing for approval for lenacapavir based on the results in one group. But what this was specifically in cisgender women, it was a 2-to-1-to-1 design over 5,000 cisgender women. 2-to-2-to-1 meant that TDF-FTC has already been studied, but TAF-FTC has not been studied in women, right? The Discover trial was in men who have sex with men and transgender women. It's only approved for non-vaginal sex. So this is the trial that was also going to look at daily FTAF in women. So 2-to-2-to-1 design, and lenacapavir was administered after the loading dose every 26 weeks. And this was a young women population. It was done in Uganda, but mainly in South Africa. And the median age was 21. And beyond the young nature of the cisgender women, there were quite a bit of STDs, over 30%, means it's a sexually active population. But despite the freely available, provided by the government, oral PrEP in both of these countries, the uptake of oral PrEP was really low, 6%. So speaks to it's not working. Daily oral PrEP is, for lots of reasons, including stigma, has not been uptaken in this population. So maybe there's something else that's needed. And much was made of this figure. Now, I want to put some caveats on it. So the figure says that at least in the endpoint of the study. Okay, so this is really important. What was the endpoint that allowed an interim analysis? It was that 50% of the participants in this trial will have reached 52 weeks of follow-up. Remember, it's given every 6 months. That means a lot of people only got one dose, right? Like 50% got 2 doses. So we don't actually have the exact median and range months, though I asked the company many times for that, because this was somewhat of an unusual interim analysis that they said you have to have 2 doses, 50%, and then they're going to stop. So I would like to, obviously we all want longer follow-up data to see what happens if 3 doses, 4 doses. So keep in mind, it's a pretty young study, but at least in this study, in that duration, lenacapavir, there were 0 infections. And the recency, the way they calculated HIV incidence was kind of convoluted, and there was lots of explanation of this, but I will say that it was pretty surprising that the TAF FTC incidence was barely different than the incidence per person years of the background HIV. Also importantly, the way that you're going to measure the way that they measured HIV incidence was not through RNA. So there is plasma stored for RNA testing, but and we're going to talk about the Levi syndrome later when we talk about our concerns about cabotegravir, whether we're concerned about that or not. But at least there's not HIV RNA testing. So you can't have like blunted HIV seroconversion going on. All that said, a lot made that there was 0 infections, at least over this time duration, with lenacapavir every 6 months. And TDF-FTC, TAF-FTC didn't look that good, But this was important that they did drug levels when they released not only the results of the trial in verbal form, but a New England Journal paper was timed simultaneously with the start of the co-chair session on Wednesday morning. So what they did is tenofovir diphosphate levels calculated in dried blood spots as the metric of adherence. And at the first visit, there were higher rates of adherence, but by the time that you got to later visits, at least by the subjective metric of adherence, there were lower rates of adherence in TDF and TAF-FTC. The issue is, I don't know if the FDA is going to say, because it doesn't look good for FTAF, right? Like, because of the incidence. So is the FDA really going to say, well, I will look at this adherence effectiveness data? I'm not aware that the FDA has ever been presented that before. There was a question asked of Linda Gale Becker at the end, and she said, I wish we could have FTAF, and I think it should be in women, and I think it works, and it works in men, and why wouldn't it work in women? But I, again, do not know if the FDA will say, let me look at an adherence effective analysis to approve a drug that doesn't look, just in terms of the hard outcome, like it's working. It really is about adherence, but let's see what they say. And then in terms of injection site reactions, I think it's important to say that the nodules at the beginning were 60%, and then supposedly they decreased over time. The pain, at least, was not significant enough to lead to discontinuations. Over 25,000 injections were given and only 4 discontinuations. The caveat I want to give is that this is a clinical trial. So let's see what happens in the real world setting with pain and nodules. We have experienced nodules not as a adverse effect, but as an absolute feature of the drug, because it is that oily depot formulation underneath the skin. And some people are fine and some people don't like it. And so I think we have to just get forward with the real time. It looks like it's a great preventative agent, but like any preventative agent, it's not going to be for everyone. And then one very nice thing is that these were all young women. They were all sexually active, and there were a fair number of pregnancies so that they could look at pregnancy outcomes with lenacapavir. And that was good because we can see that there weren't differences with the outcomes of the pregnancies with lenacapavir versus the oral drugs, which is, there was no reason to believe that lenacapavir would have adverse effects in pregnancy. So I think this is enough, at least, I hope, to assuage any concern that this shouldn't be used in women of childbearing age. Now, this is what you get from being at a meeting, that it really felt like this was the biggest topic in terms of protest. So what happened is when the chief of UNAIDS gave her talk at the opening session, she said, lenacapavir looks like a miracle. This is before it was presented, and Gilead, make it happen. And beyond her statements, there were a lot of protests in the global village that would spontaneously erupt of what's going to happen with accessibility. And one issue that came up is that there was a poster. It wasn't an oral presentation by Andrew Hill that got quite a bit of press, that he and his colleagues calculated that lenacapavir could be made for $40 a year. I don't know if that's true. And I have to say that the price point is sort of all over the place. I've heard of estimates from Gilead from 12,000 to up to 43,000 a year. So lot of commentary to Gilead based on the rollout of CAB, which has been pretty dismal, that there has to be a way figured out to make this accessible, because that was really the main question that kept coming up. And voluntary licensing, whatever happens, it has to be different than what happened with cabotegravir and rilpivirine. Okay, so what about some additional data in terms of prevention? Well, I thought this was important data from HPTN 084, which looked at, this was, of course, this definitive study that showed that cabotegravir every 8 weeks was not just non-inferior, but far superior to daily oral TDF-FTC among cisgender women. 89% superior. And the reason this is helpful is these are young, sexually active women, and thus there were a certain degree of pregnancies. And so there were 2 reports given from HPTN 084. This was an oral abstract on pregnancy outcomes. And they also, since they had gone into the open label extension phase, did have infant outcomes. So no difference in terms of things like preterm birth, pregnancy outcomes, or size of infant, gestational age, look like cabotegravir versus no cabotegravir, no adverse effects on pregnancy or infant outcomes. I think this should hopefully get into the guidelines, because I don't think we're going to ever get more data than this. And there was never a concern for cabotegravir in pregnancy. Okay, this is the next thing that I want to talk about in terms of prevention, but let's start out with a question. Should we check HIV RNA every 2 months on long-acting cabotegravir? Well, yeah, that's what the CDC guidelines say, number one. 2, no, that's not what the WHO guidelines say. 3, yes, but keep in mind what the HIV RNA level is, and that matters. Or 4, yes, we cannot afford to miss long-acting early viral inhibition syndrome. We can blunt the response of the antigen antibodies, so we need to do HIV RNA testing. So please vote. Okay, so yeah, go ahead. Yes.
So question from the chat was excellent. Someone asked, so cisgender women have to wait for the data on men when other drugs have been approved for men only. Can you make that make sense? So if you comment on FDA.
Yeah. That's a very, very good question, because as we know, Discover was the trial with TAF-FTC, and never did a trial in women before this, and it was approved for non-vaginal sex. And then on-demand TDF-FTC actually is not approved. Did you know? Like, it's not in the CDC guidance for a variety of reasons, even though it clearly works. But that never has been studied in cisgender women. So really, really good question. It was not even addressed. There was just this comment that they would want to present all the data together. But I think that's a really excellent question, why we couldn't try cisgender women now. I do have to say, though, having longer follow-up is going to be good. I thought that was a very quick interim analysis, and I'm curious to see the data that we're going to get at CROI from Purpose 1 follow-up as we get the Purpose 2 initial results, I think, at CROI. I think both of those are going to be helpful. So this is a very dutiful audience. They said, most of you said, yes, let's do it. That's what the CDC guidelines say. But actually then everyone was sort of divided into the other responses. And 25% of you said, no, we shouldn't be doing HIV RNA testing every 2 months. I'm firmly in B, but let me explain why. So data that was presented at this meeting was good. It was from the HPTN 083, which we not only have the initial data that showed that cabotegravir was 66% superior over daily oral TDF-FTC among men who have sex with men and transgender women, but we also have a follow-up Lancet HIV article from the open label extension phase of HPTN 083. And what they did, HPTN 083, there was a lot more sort of extensive analyses on failures, because interestingly, and I didn't actually go over this clearly, there were only 6 failures in HPTN 084, and none of them failed with INSTI resistance. I think that has to do with the fact that women have higher drug levels than men with cabotegravir, but there were failures in HPTN 083, so there could be analyses of these failures. There was actually 34 failures and 18 failed with INSTI resistance. So we want to look at these failures closely. Now, the CDC guidance in 2021, after the results of HPTN 083 and several presentations by the group on Levi syndrome and early blunting of response, did say, let's do HIV RNA testing every 2 months when you're on cabotegravir. By doing that, they have relegated people who are living without HIV to 6 viral loads a year, when you're getting HIV viral load testing 1 or 2 times a year for those living with HIV. They have also, it's not logistically feasible, it's not practical, it's not endorsed by the WHO on their 2022 WHO prevention guidelines for cabotegravir. But right now, if you look at the CDC guidance right now on Google, they will say HIV antigen antibody at start, at initiation, not an HIV RNA, of all times, and then HIV RNA every 2 months. So what was presented at AIDS 2024? So this was presented by Rafi Landowitz from afar, and essentially drilled down on these 22 failures where they were supposedly failures if you looked at HIV RNA testing, and on further testing, they were all negative. None of them had seroconverted. These 22 failures, quote failures, again, they had a lot of delays because once you see an HIV RNA level that's positive, you stop the cabotegravir. They should have been put on ART, but not all of them were. And of those 22 false positive, falsely characterized failures, every single one of them had low-level HIV RNA. They were all less than 200. So essentially, this is not in the presentation, but in the question answer period. The first author of this study just came right out and said, we got to stop doing HIV RNA testing. It should not be based on HP 10083. It is going to confuse people. It delays the administration of cabotegravir. It can lead to problems, and there's no reason for it. And so very clear message. And at least from personal communication with the CDC, they're going to take out the HIV RNA testing every 2 months and add HIV RNA testing at initiation, partially based on some of Kate Koss's data on seroconversion that it can occur when you are giving cabotegravir in the face of an early infection. But I will say that they haven't done it yet. So we have done it. We, in our PrEP guidelines from our clinic, we do not do HIV RNA testing every 2 months. Okay, and then this is the final abstract on prevention. After data at AIDS 2024, can we now use Cabril sub-Q instead of intramuscular? Are we good with that? And the answer is no, it needs to stay intramuscular, or yes, it's time to have that option for intramuscular versus subcutaneous. What do you think? Everyone is saying no. They are correct. You are correct. So essentially, this was a look. This was actually done in the FLAIR study. That there was a sub-study in FLAIR, which was, of course, the study of Cabril in treatment-naive patients who were first put on dolutegravir, bacavir, 3TC for 20 weeks and then switched over to long-acting. And the sub-study, just like the direct-to-inject study, just looked at a specific administration of subcutaneous. And interestingly, the PK was the same. So subcutaneous did not lead to different PK levels than intramuscular administration, but it hurt. And in fact, patient-reported outcomes far exceeded intramuscular was far preferred over sub-Q. So there's not going to be continuation by the drug company of the pursuit of the subcutaneous formulation. So we have to do intramuscular for this, which is okay. Then you don't get nodules. Okay, so let's move to HIV treatment. Now, when we do treatment, I'm going to talk about some resistance in here. So this is a question for the fellows who are going to be all really familiar with every single one of these trial names by the end of this year. But which studies looked at a combination of an integrate? What studies have looked at a combination of an integrase inhibitor and a capsid inhibitor? Have there been no studies? Maybe a case series or two, but no studies. Is that Capella? Number 3, is that Artistry 1? Is it Artistry 1 and Calibrate, or was that going to be Purpose 2? So please vote. So this is a, know your trial names question. And because this is a very astute audience, there's some division between these other numbers. Some people say none, but 33% of you say it's Artistry 1 and Calibrate, which is the correct answer. So taking a step back, Calibrate was not presented at AIDS 2024, but let me remind you of what that study was. Calibrate, its final analyses was published last year in the Lancet HIV. And this study was phase 2. So it's not going to lead to approval. But what this study looked at was people who were naive to therapy, randomizing to lenacapavir with oral FTAF, and then there was even an arm of lenacapavir with bictegravir. Not something that we can do. We can't take out bictegravir. Maybe the drug company can, but we can't. But it was a lenacapavir with bictegravir arm, and then it was compared against Bic, TAF, FTC. And again, phase 2 can't lead to approval, but it did look like Bic and Len together that was an INSTI and a capsid inhibitor, led to maintenance of, or led to high rates of virologic suppression. And these were naive. So they all started with whatever viral load they started with. So didn't lead to approval, but was an interesting proof of concept. So what's the study that was presented at AIDS 2024 that's a follow-up of what was presented at CROI 2024? This is the Artistry-1 study. So the design here is the idea that maybe you'd want a single pill combination of bictegravir and lenacapavir, only that same drug company can put those two together, and it's a single pill combination. And the dose that got settled upon was bictegravir 75 milligrams and lenacapavir 50 milligrams daily. The 24-week data was presented at CROI 2024. This is the 48-week data, and it actually is a larger sample size, so it's going now into getting into phase 3 numbers. And essentially what it showed is that there were high rates of virologic suppression that were maintained if you switched, if you got switched over to Bic-Len. Just like is very common with this drug company, this company doesn't tend to do studies in patients with viremia. It's kind of a switch study design where it's kind of easier, right? Because you're already virologically suppressed, but the maintenance of virologic suppression was seen. So by the way, the abstract numbers are in pink here at the bottom with the first author. So so it looks like this is probably something that will be pursued, but it gives this proof of concept that an integrase inhibitor and a capsid inhibitor, why not, is going to work. And it gives us interest in the HIV community with an capsid inhibitor and an integrase inhibitor that are made by two different companies but are already approved, which is lenacapavir and cabotegravir. So there isn't data on lenacapavir and cabotegravir, though many of us have a lot of interest in that. And in our SPLASH program, we certainly have patients on that. And so do people around the country, because they're off-label using lenacapavir, cabotegravir, because this is the only long-acting regimen that you can use, especially if there's NNRTI resistance. So this was a case series we put together last year that was an OFID about lenacapavir and cabotegravir, just 34 people, but it did increase virologic suppression in people who got that long-acting combination. Absolute asynchronous, lenacapavir 6 months, cabotegravir is every 2 months. So is there any study that's coming up for lenacapavir, cabotegravir? There is. It's going to be in the ACTG. It's teeny tiny though. It's only 30 people, but at least it has been approved. Really gratified that the two drug companies that make these two products have agreed to provide the drug for the ACTG to do this small trial of Len-Cab in the ACTG, but there are a lot of groups that are asking from around the world for this combination, and those other studies have not yet been approved. I hope this ACTG study will open the door, because if you wait for an integrase inhibitor from ViiV that's long acting, and if you wait for a capsid inhibitor from the other company, or sorry, I should say the opposite. If you wait for their phase 1 studies of their matching products, it's going to take too long. And these two drugs are already available, and we really do want to put them together in the HIV community. Speaking of, though, kind of development, drugs that are going to come down, there is a 3rd generation integrase inhibitor that's being developed by ViiV, and this is a product called VH184, and this is just phase 1. I mean, this is just serial passage through looking at in vitro data, but this is being designed with the idea that it could overcome dolutegravir-associated mutations, and at least in vitro, VH184 looks like it will maintain antiviral activity against INSTI-related RAMs. So that has to go through so many phases until we can get to it. And it does look like the PK will favor some long-acting administration. Okay, another, Grace is not here, but she would know because she presented on this last week. This is another for the fellows, because they all know the trials in and out now. Which 2 studies were updated at AIDS 2024 looking at dolutegravir in the face of NRTI resistance? Did we get updates from Nadia and Donning? Was it 2SD and DEFT? Was it Vicend and Nadia? Was it Vicend and DEFT? Or was it Nadia and 2SD? This is a, you have to just want to know these studies. Okay, so 40% said Vicend and Nadia. Nadia's done. So that 96-week data was presented and that's done. But the rest of you got it correct, which is Vicend and DEFT. They are now done after the data that was presented at AIDS 2024. So great job on this. So what are these studies again? Let's just put this together all in one table. There are 5 studies that have, because right, like dolutegravir, tenofovir, lamivudine, TLD was approved in 2018 with a little bit of a glitch, and 2019 for everyone by the WHO as first-line therapy. But then quickly the question was, can it be second-line therapy in the face of NRTI resistance? We've had efavirenz, TDF, FTC as first-line therapy for years, and there's enough NRTI resistance in the face of treatment failure with NRTI-based regimens that we want to see if dolutegravir can uphold efficacy in the face of NRTI resistance and not have to go to a PI. So now, based on the results of these studies, dolutegravir is second-line therapy in the face of NRTI resistance, because Donning, Nadia, Vicend, 2SD, and DEFT all were studies that compared dolutegravir with 2 NRTIs versus a boosted PI with 2 NRTIs in the face of NRTI resistance. And Donning, Nadia, and a 2SD are done, and the results are shown here. And you can see that dolutegravir in all 3 of those were all non-inferior to the boosted PI, even darunavir. There was, however, some cracks over here, right? Like in the resistance column, which is column 4, if you fail with dolutegravir, there is a certain degree of resistance. It was highest in the Nadia study, 4%, and actually in 2SD, at least at 48 weeks, and this is all in abstract form, they've not published this, no emergent resistance at 48 weeks. But some cracks with dolutegravir and leading to resistance that we didn't see with darunavir. So what happened at AIDS 2024? The 144-week data from Vicend was presented, and the 96-week data from DEFT was presented. And these 2 data points close out these studies. And I will say that Vicend, interestingly, there was no dolutegravir resistance seen at 144 weeks. There was actually atazanavir and lopinavir resistance. And DEFT, there was 4%, or sorry, there was 0.7% resistance in the dolutegravir arm. So let's go into those in more detail. The 48-week results of DEFT had actually just been published in the Lancet HIV 2 months before the meeting. This is the 96-week data. The design of DEFT is standard of care, darunavir, ritonavir, 2 NRTIs, that's what they called standard of care. And they called the intervention arm with NRTI resistance the arm of dolutegravir with darunavir, ritonavir versus dolutegravir with 2 NRTIs. Lots of NRTI resistance, recycling tenofovir, even when you think it won't work. And just like the other studies, dolutegravir with 2 NRTIs, even with supposedly tenofovir-associated mutations, works. So essentially, this is a little interesting because this was an update from the 48-week data, which had shown non-inferiority of the arms with a superiority of dolutegravir with darunavir. There was something made of that at CROI 2023, but no reason to go to that arm, meaning we don't want to use protease inhibitors if we can't. So that certainly didn't lead to any change in the WHO guidelines, which is absolutely appropriate. But in this case, actually both dolutegravir arms together were superior to darunavir, ritonavir with TDF-FTC in the 96-week analysis of DEFT. So it just means that dolutegravir is a really good drug. It's right for it to be second line. Doesn't mean that there's not some resistance that's peeking through if you have 25 million people on TLD, which is how many people are on TLD. But it is a really good drug, and I think that just keeps reminding us of that. That's what I think Vicend did. And interestingly, and this will come up in the comorbidities section, weight gain was higher in the 2 dolutegravir arms. So that PI with TDF-FTC may not lead to as much weight gain. And this was the first study that we actually got statistical significance of that. So dolutegravir with, has been associated with weight gain. This is not a surprise at all, but it was good to see this data. And then the Vicend study, this is 144-week data. And what this did was look at dolutegravir either with TDF or with TAF, compared to boosted PIs that we don't want to use, which are atazanavir and lopinavir, though they're still on the WHO guidelines. It was interesting. I went to a session on INSTIs, and the head of the WHO treatment section was there, and she was asked by Nick Patton, can you please take away atazanavir and lopinavir from the guidelines? And she said, we already have, but no, they're still in there. But I think these studies have really shown the superiority of darunavir over atazanavir, lopinavir, and Vicend kind of puts that nail in that coffin, because there was PI resistance that emerged on atazanavir and lopinavir in a way that has never emerged on darunavir, but it is still in the guidelines of any of the boosted PIs. So 140-week data and a non-inferiority of dolutegravir to the PI arms. Okay. So we have to end with resistance. This is a very select group, so please don't get worried. And there's not a lot of data on this, but I do want to see your thoughts on what was the rate of INSTI resistance in the IDEA cohort, which is an observational cohort across different countries in Africa, among those with virologic failure on TLD, specifically who have a history of treatment experience with NRTIs. Is it 4%, 8%, 10%? 20% or 40%? Okay, so you so far very fairly are coming up with these low numbers of 4%, which is, I think, the right number in people on TLD who are failing in general. But this is a very specific subset, and that's those with treatment experience. So that would be what? Those would be like the people in Nadia, right? Like where there is NRTI resistance. And this will predispose you, if you're failing, to having dolutegravir be a monotherapy agent. And maybe the rate of resistance will be higher. And that is what happened in this IDEA cohort. This was in poster, not oral form. This is the only poster I think I'm going to present, but this is the dolutegravir resist study. And it's from the International Epidemiology Databases to evaluate AIDS. And essentially the design here is this was done in 12 African countries, 12 sites, 7 African countries. And not that many sequences, 152 sequences, 148 had integrase genotyping being able to be done. But all of these patients had 2 elevated viral loads, which is the definition of failure, not just one. And they all had treatment experience. And at least in that setting, the rate of resistance was 22%. And there are 2 data sets that confirm that higher number, again, in the case of NRTI resistance. One is from Malawi that was in the WHO February 29th, 2024 surveillance statistics. And the other one was an analysis that was presented at the 30th International Workshop on Resistance in Cape Town last year, and it was from South Africa. So it's this specific population, treatment experience, persistent virologic failure, where you can see that emergence of dolutegravir failure. And we just need good ways to figure out who need to be surveilled for dolutegravir resistance. And then I'm going to end in this treatment section with long-acting. Not much data on long-acting. A lot of discussion of the accessibility of long-acting. It was everywhere. It was in commentary from moderators. It was in the Global Village. It was the first author of this study, which is the CARE study that Dr. Havler presented last week, actually said to me verbally, I wish we had never done the CARE study because there's no accessibility. That's how this was the kind of ethos that was happening at this meeting. And this was presented last week at our launch of HIV Grand Round. So there was not updated data from CARES at AIDS 2024, but I just want to remind you that this is supposed to go to 96 weeks. This is the study of CARES' long-acting cabotegravir and ropivirine in those who are virologically suppressed in Uganda, Kenya, and South Africa. Everyone's virologically suppressed. 90.6% are on TLD, and they get switched over every 8 weeks in one arm to long-acting Cabril, and high rates of virologic suppression were maintained. Very interested in the 96-week data. Everyone's interested in that, and I think that will be at CROI. So what was presented at this meeting? What was presented was the 48-week data from the IMPACT 2017 data. So this is a question for you. In Impact 2017 or MOCA, what percent of participants preferred long-acting ART to oral ART? Was it 50%, 60%, 75%, 90%, or 100%? These were in quality of life surveys performed at the 48-week mark. So rarely is something 100, but it was 100, at least in these 140 participants, every single adolescent said I want long acting. So let's go over that data. The 24-week data of Impact 2017 or the MOCA study was presented at CROI 2024. This is the 48-week data. And this is a single arm trial. This is not randomization. These are 144 adolescents enrolled from 18 global sites, including US, Uganda, Botswana, South Africa, and Thailand. And the design was they were all suppressed on whatever they were taking. 92% had acquired HIV from vertical transmission, which means by definition, they have a lot of treatment experience. I'm sure they've had a lot of NNRTI experience. I'm sure they have resistance, not that they did that. But the design was switching them over to long-acting Cabril, just like in the CARE study. If you're suppressed, switch over no matter what your treatment experience or resistance was in your background. And interestingly, and it's maintained at 48 weeks, really high rates of maintenance of virologic suppression, 97%, and no cases of confirmed virologic failure, even at 48 weeks. It's making me think that we can use Cabril even in the face of whatever's archived in terms of NNRTI resistance, really. But looked good. And the PK looked good. And this is approved down to 12 years old and 35 kilograms. So go forth and using with adolescents. But then the moderator of the session, who was Chloe Orkin, after this presentation took 2 minutes to say, this is not available. And that's a problem. And she specifically called out the drug company that makes rilpivirine, which, to be fair, seems to not be making rilpivirine accessible. And I think the drug company that makes cabotegravir has to just license the rilpivirine and make it available. But lots, again, of just really wanting to point out that if you were there, the degree of commentary on accessibility very fairly was really prominent. Oh, and then also every single one of the participants said, I like long acting. There wasn't one who wanted oral. Okay. So let's go to the last treatment study, which is from Solar 3D. Should we use dolutegravir 3TC in those with M184 mutations? Is the answer yes, or is it no, 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 no? So you can answer. And if anyone answers yes, I am going to come and find you. So this was so interesting. And again, like it can only happen if you're there. I'm not even going to tell you the design of this study because I don't want to. It was 100 people. And it essentially took people who were all virologically suppressed on 3 drugs. 50% of them were on dolutegravir, abacavir, and 3TC. And they were brought down to dolutegravir 3TC, and they all had M184Vs. The reason I'm not going to tell you the design of the trial or show you any data from it is I want to tell you about the 2 question and answers that decimated the study. And Steve Deeks and I were texting in the middle, and we were like, they're not really saying this, right? And then luckily 2 questioners came and just killed it. So 2 things. One is that the study investigator said, we have to use, based on this data, 2-drug therapy because 3-drug therapy is associated with increased morbidity and mortality. And then he actually used this phrase, and these are people. These are people. And so Laura Waters from the UK got up and said, well, can you please point to me the data that 3-drug therapy is associated with mortality? And he said, no, there's no data, but it's just a gut feeling. And then Trip Gulick pointed out that these are only 100 people. 50% of them were on dolutegravir, abacavir, 3TC. When you're suppressed and you go down to, drop one of the drugs, they did stay suppressed. But he said, can you really conclude that that means everyone in the world should be on dolutegravir, 3TC? And it was really hard to conclude that, I think. So it just wasn't the data set. We all know from CROI 2018 that we don't use dolutegravir monotherapy. Don't do it. We're not going to do this. Don't use this with an M184V. Don't do it. Okay, let's turn in the final part to comorbidities and cure. So comorbidities, we're in the INSTI era. So everything I'm going to talk about is INSTIs, right? So we're in the INSTI era. It's Big TAF FTC in higher income countries. It's dolutegravir, tenofovir, lamivudine everywhere else. So my question, and this is really something I would be interested in hearing the answer to, is what would you switch someone on Big TAF FTC with weight gain to in terms of ART based on the data to date for weight loss? Would you switch them to dolutegravir 3TC based on Paso Doble, which was presented at ACE 2024? Would you take them to dolutegravir TDF FTC based on the Characterize study? Would you put them on darunavir Cobi TAF FTC based on Define and maybe even the DEFT study? Would you put them on doravirine TDF 3TC based on the DO-IT trial and the ACTG? Or do you not think the data is compelling enough in any of these to make ART switches for weight gain? And let's work on other strategies for weight loss. Very curious what you think. So 33% of you think we don't have the data, and that's probably right, but I do want to tell you about some of these studies that have looked at what happens if you switch therapy. The number D, we don't have the results of, but ABC, we do have the results of all three of those. And the 48-week data of Define and the Paso Doble were both presented at AIDS 2024. So let me tell you about these. Weight gain, I remember because I talked to Diane right after the session. This was the first, it was CROI 2019 when all of this kind of came about. 2013 was when dolutegravir was approved. We had enough data by then to really look at what's the impact of second generation integrase inhibitors with TAF on weight gain. And it was being observed in observational cohorts that combination of big TAF or dolutegravir TAF was associated with weight gain. And those were observational, but it was this 2019 study that Diane commented upon in a New England Journal editorial, which was the advanced study that really says, okay, where this idea came from that dolutegravir TAF in a randomized fashion was associated with more weight gain in women more than men. And you've all reviewed this data and that weight gain kept on going with TAF. So I want to remind you that there is a study called the Characterize study that was published in CID last year by Bosch et al. That took 152 of the individuals on dolutegravir TAF FTC and moved them back to dolutegravir TDF 3TC, 172. And the results are in the CID paper, which is on the top right, but there was weight loss actually switching down to TDF, but only in women, but it was statistically significant and it was about 1.6 kilograms. So maybe some food for thought that TDF, we all sort of have decided in 2024 that we're at a point where we think that's a weight loss agent or an anorectic agent or something about that. And that was really shown out in the Characterize study. What was presented at AIDS 2024? The first one was the Paso Doble study. And what this was taking individuals who were all suppressed on their regimen of whatever they were using and randomizing them, this was done in Spain, to dolutegravir 3TC versus BIC TAF FTC. Primary endpoint was virologic suppression. Virologic suppression was maintained. None of them had a history of M184V. And weight gain was the secondary endpoint. So virologic suppression was maintained. I'll skip past that. Weight change, there was more weight gain in those who were on switched over to BIC TAF FTC. You can see that the absolute weight gain that's shown in this figure here. And then what I'm not showing you is that if you look at greater than 5% weight gain, that was 29.9% of those on BIC TAF FTC versus 20% on those of dolutegravir 3TC. So it was very interesting to say that, because everyone wants to know, well, what were they on before? Did we lose the anorectic effect of TDF? And indeed, it is true that weight gain in the BIC TAF FTC arm depended on pre-switch NRTI. It was actually both abacavir and TDF, which hadn't heard of abacavir being a kind of anorectic agent. But interestingly, the weight gain in the dolutegravir 3TC arm was not dependent on the pre-existing NRTI. And the bottom line is there's no doubt that TAF and second generation INSTIs are associated with weight gain. And I think you have to decide if you think this data is compelling enough that you would take someone and take them down to dolutegravir 3TC. Again, that's not the design of the study. It's not big TAF FTC taking them down to dolutegravir 3TC, though we've been discussing this in Fellows Clinic. And then I want to end with the DEFINE study. The 24-week data had already been presented. This is the 48-week data. The DEFINE study is actually taking people who already had a lot of weight gain on their INSTI plus TAF. In fact, all of them had over 10% weight gain, and the BMI median was 37 BMI and over 100 kilograms. And the question is, could you take them to darunavir, Cobi, TAF, FTC, and would they lose weight? Well, we already had the 24-week data that there was no weight loss. This is the 48-week data. And I listened to the presentation carefully last night again to just like really understand if they're making a claim. They're kind of making a claim that this is done by the drug company that makes darunavir, Cobi, TAF, FTC, but they're saying that at 48-week data, there was a trend towards losing weight in the dolutegravir, TAF, Cobi, TAF, FTC arm. And you can see that trend. And they're saying, well, maybe if you do it for longer than 48 weeks, it'll be statistically significant. We don't know that. But I do think that the data from this and DEFT does tell us that dolutegravir, Cobi, FTC, TAF isn't a weight gain agent. Maybe that's all it tells us. And I don't know if you're willing with this limited data and this trend to switch over for that. I think instead we have to work on other cardiometabolic optimization of our patients living with HIV in our clinic. And please stay tuned for provider meeting in 2 weeks, because we've been doing it. We've been putting an alert, we have statins, and we're going to show you some data that we have been better at statin use in our clinic after the REPRIEVE study. And then I'll end with the AFRICOS study. The AFRICOS study was, there was just all of this observational data. And unfortunately, people who look at observational data with all its confounders were making, I think, unsubstantiated claims that dolutegravir leads to incident hypertension. We just didn't have that data, but we needed a prospective study to look at that, and that's the AFRICOS study. It is in Kenya, Nigeria, Tanzania, and Uganda, and it was that prospective study. You know the date that someone started on dolutegravir versus other drugs, and you measure blood pressure every 6 months. And essentially, there were 3.4 years of follow-up in dolutegravir, so you're going to have enough incidence of hypertension. In fact, there was a 13% incidence of hypertension, and there's no evidence that dolutegravir is associated with incident hypertension. Let's put that away. Maybe nevirapine is, but you know what? We don't use nevirapine. Okay, and then I'm going to end with this so we have time for questions. What was a unique feature of the 7th cure presented at AIDS 2024? Was it that this person didn't get a stem or bone marrow transplant? Was it that the donor, they did get a stem cell transplant, but the donor had a homozygous 32 base pair deletion? Was it the donor had heterozygous? No, the donor had homozygous 32 base pair deletion and the recipient was heterozygous, or were they both heterozygous? What's the answer, do you think? Questions? Okay, you know what? You all said the right answer, which is D. This was just super cool because this particular person had that heterozygous, only one of the parents had a 32 base pair deletion in CCR5, and the donor had a 32 base pair deletion in CCR5, and they've been in remission for 5.5 years. So that was interesting. Maybe you just need half of the CCR5. So let's end there so that I can get to your questions. Thank you.
Thank you, Monica. That was fantastic. We'll start with the audience. Any questions?
Thanks so much, Monica. Outstanding as always. I had a question about the data that you presented comparing dolutegravir versus darunavir and more weight gain sort of earlier on in the presentation. I wondered what proportion of people were on TDF and therefore then had boosted TDF in the darunavir arm.
That's a great question. Because in the dolutegravir, darunavir, ritonavir arm, they would have boosting of their TDF. They were all on TDF because this was in low and middle income countries, but they would also get that boosting with darunavir, ritonavir, TDF, FTC, right? Like and they didn't see that weight gain there. So I don't know, but I do think all we can conclude, and we're going to be talking about this, you too, so much in Phil's clinic, if you're willing to go, if we're ever going to make switches. We did do this last year with one of Gergen's patients. We just could not get his weight gain to stop. And we put him on a Fabrin's TDF FTC, I will tell you that. So we wanted both anorectic agents. Nothing could reverse it. So I think it's just going to be a case-by-case basis. Great question.
Yeah, agree. While people are thinking, we have another dolutegravir question. In dolutegravir resist, do we know how many of the patients with INSTI resistance were on TLD as second-line therapy and therefore are likely to have had prior NRTI resistance versus first-line failure?
Yeah, I mean, all of the ones that ended up having resistance were on TLD as second-line therapy. That is labeled TLD2. And I will tell you that we just wrote a grant where we really reviewed the data on dolutegravir resistance, and the risk factor is exactly what you just said, is being on TLD for second line, but importantly, having prolonged virologic failure. If you take the medication every day, hopefully you can avoid this. But if you can't, then you're going to be off and on, and then you're going to get resistance to dolutegravir.
Yeah, I'm going to keep going, but anyone in the audience, please interrupt us. This is a back to PrEP question. How do you decide, what do you think is optimal, Dr. Gandhi, about when to do viral load testing on injectable CAB for PrEP, aside from initiation? Is it symptoms, late injection, presumably, and presumably still doing 4th gen testing with each injection? Question mark.
That's a great question. One thing I failed to mention in the HP10083 presentation is that if you had missed injections, that it was most likely to be a true positive. So I think what we have put in our guidelines, and Matt drafted them, and I still have to look at them more closely, and we'll put it out and we'll get everyone's input, is we're going to do HIV RNA testing at initiation. And then if you have missed injections, we'll do it then. Or I think it's a great point that if, of course, you have symptoms of seroconversion, no doubt we'll do HIV RNA testing. But otherwise, this routine testing is leading to false positives, it's leading to anguish, it's leading to starting on ART, it's not the right approach. And I keep on waiting for the CDC to change it, but they're not changing it. They told me they change it. Jonathan Merman told me they change it.
I was just going to add the add-on that most people who had Levi syndrome didn't have symptoms of seroconversion, so it'd be pretty, unfortunately, yeah, these are pretty low viral load, no symptoms, seroconversions that happen. So that won't be a clue, but I think great point about the late injections. Yeah,
it's very interesting with HP10083 because one author from it will make much of Levi, and then the other author is just like, I'm not worried about this. And whenever they present, they go back and forth, and it's dizzying. Yeah. One's lab-based and one's clinical-based. And I think that's an important distinction of those people.
I can add on a question for you about the false positive, or sort of how we're using the term false positive, and whether these were thought to be, sort of very early averted cases of HIV, or whether they're falsely positive because they're different samples, or sort of how that false positive is being.
They were actually, most of the low-level false positives were from the same site, they pointed out. So there's some issue with that lab. But if you have a low level, don't worry about it. We just Kate got it like 2 weeks ago. She had a HIV RNA of less than 200, and we just plowed ahead with cabotegravir.
Okay, we have, see if we can get to 2 more questions. There is a question about, I think this is in reference to the conversation around sort of dolutegravir monotherapy, and for studies on INSTI plus NRTIs in the context of treatment experienced patients, how would that affect your practice? Has anything that was presented recently affected your practice in the US, where we are genotyping? If, for example, you were worried about NRTI resistance, TDF, FTC.
We are lucky in the US because that is the difference, right? Like we have darunavir and we also have it as a single pill combination. And yes, if there's a lot of NRTI resistance, I'm not going to use TLD. I'm not. And this is the setting in which darunavir, it has to be boosted and you suddenly have TB and that's hard. And then the availability still may be atazanavir or lopinavir, which I do not think those are the right drugs. And neither does Nick Patton, the first author of the Nadia study, who's really upset. So I think it's it's going to be different in high income versus low income. What yet another disparity? I would not use with lots of resistance. I would not use the second generation INSTI with NRTI resistance.
Thank you. Last question. This is a fun one. Monica, if you were to design your own ART switch for a weight loss trial, which agents would you want to study?
That's such a good question. I mean, the DO-IT study is doravirine TDF FTC because TDF is anorexic and we don't want to use efavirenz anymore. So we're like using its cousin, and NRTIs have never been associated with weight gain. So I do think that doravirine TDF3TC is the right thing. The question is, do you want to use TDF, especially when people are older for a long time? And I'm not sure about that. So I think dolutegravir 3TC, a proper study where you just take people on big TAF FTC and switch them to dolutegravir 3TC, that's the study I want to see. That's not what pasa doble is.
Thank you so much. Thank you, everybody.
Thank you.